well. My name is Dr. Lisa Lilienfield, if you don't know me, and I've been working with Dr. Kaplan for many years at Kaplan Center for Integrative Medicine. And on behalf of my colleagues at Kaplan Center, I want to welcome you to this exciting event and tell you how proud and thrilled we are in the launching of Total Recovery by Dr. Gary Kaplan. He has touched so many lives and created a loyal following amongst patients, colleagues, and friends. I've known Dr. Kaplan for 30 years, and he is a good friend, and he's a brilliant doctor. He is patient, he's caring, he has an inquiring mind, and he's always searching for solutions for what ails his patients, and he never gives up, and he thinks outside the box. So I want to read you a few of his credentials, which are quite impressive. Dr. Kaplan graduated from College of Osteopathy in Des Moines. He did his residency at Georgetown Hospital School of Medicine and Family Medicine. He's one of the few who are board certified in pain management and family medicine, also board certified in medical acupuncture. He's a fellow of the American Board of Medical Acupuncture. He's worked with NIH to establish medical acupuncture as medically effective treatment for chronic pain. He's trained many physicians in medical acupuncture through UCLA Helms Institute. He's a clinical associate professor at Georgetown in family medicine. He's past president of Medical Acupuncture Research Foundation and Virginia Osteopathic Medical Association. He has his name on many research papers and many chapters in books on pain management. He founded Kaplan Clinic in 1985 in Arlington, and now it's in McLean, called Kaplan Center for Integrative Medicine. Total Recovery is on sale and over here, and he'd be happy to also answer questions after the lecture, but if you'd like your copy signed, he can spend some time with you. So join me in warmly welcoming Dr. Gary Kaplan.
Thank you, Lisa. So life is about journeys, and tonight, one of the journeys was getting through the torrential downpours and the traffic, and I appreciate all of you coming out here. I know it was no small feat for what I had to go through getting here as well. Life has also been a journey over the last 30 years in learning about pain and learning about depression and learning about how to fix these problems, learning about this from all of you, and learning about this from many of my very talented professors and colleagues who've joined me on this journey. We are talking tonight not about suffering, but suffering is the subtext, but we're talking about recovery from suffering. And to start the journey in recovering from suffering, we have to think about things a bit differently. So the first question is, what if the beginning isn't the beginning? I start my histories when I work with patients differently. I say to them, when was the last time you felt totally healthy, vibrant, and well? And the first thing they do, and many of you have done, is lie to me. You don't mean to lie to me, but you lie to me anyway. It happened 4 years ago, Christmas Day. I remember it like it was yesterday. It happened three weeks ago when I slipped and sprained my ankle. So let me talk to you about Alex. Alex is a 17-year-old young woman who came to see me a number of years ago. Alex had, when she was 15 years old, been kicked in the knee. Developed severe swelling, severe pain in the knee. Originally, 6 weeks, you're going to be better, let's put you on crutches, everything will be fine. Unfortunately, that was not the case. What happened was the pain got progressively worse and worse. Eventually, Alex is diagnosed with reflex sympathetic dystrophy, but not by the first orthopedist who sees her, or the second orthopedist who sees her, or the pain specialist who sees her, or the psychiatrist that she's eventually sent to because they've decided she's crazy. And I know many of you have had that experience, and I hear that all too often. But by a physical therapist who sees her and says, you know, this looks like reflex sympathetic dystrophy. Then she goes back to another pain specialist and he says, I think she's right. And so the journey begins. And Alex goes through a horrific series of treatments and mistreatments. She's seen up at Boston Children's, she goes through a couple of surgeries. She's eventually seen at Children's Hospital where they put her through a really arduous program where they have these kids who suffer from this problem carrying sacks of barley through the halls. They have them going through very vigorous physical therapy. And the whole thing is about resetting the pain receptors. And when you ask them, okay, what are you doing? And they say, well, we don't know, but it does seem to work as long as we get the kids who are under 15 years of age. 16 years, we might get away with it, 17, not happening. But Alex is a trooper, and after 3 weeks of going through this program, is dramatically better, able to return to school, able to re-engage with friends. But fatigue becomes a significant problem in her life. She starts having headaches, and the headaches are getting progressively worse and progressively disabling. She's heading right back down the path she was on to begin with. That's when we get to see Alex. So now we're 2 years into the event. And so the question is, when did it begin? Well, it began during the spring when I was out playing soccer and I got kicked in the knee. Okay, let's take the history back a little more because everybody's been focused on that. What else is true about you? Well, what else is true about her, as we find, is that she's had Lyme disease. Not once, but twice. We also find out that she was bitten by a poisonous spider. This happened about 3 or 4 years prior to the onset of this illness. And the mistake we keep making is we assume that the event is the onset. We don't think about the setup. Why would an otherwise healthy 15-year-old young woman get kicked in the knee, and where every other 15-year-old on the planet 6 weeks later would recover and be fine, this kid goes into severe, excruciating chronic pain? The answer in her case turned out to be biotoxicity disorder. It was not the continuation of the Lyme, but toxins as a consequence that were released from the Lyme and from the poisonous spider that were still circulating in her system. We treated her for that condition, then subsequently treated for her headaches, and then everything got better. And we were able to ship her off to college. Now, this was early on when we were looking at this biotoxicity stuff, and then she gave us a gift, a strange gift, but a gift. The gift was she goes off to college 100%. She gets bit by another poisonous spider. Now, I don't know about you guys, but I've never been bit by a poisonous spider. This kid is attracting ticks and spiders. And everything comes rip-roaring back on her. The headaches, the fatigue. She's horribly sick again. They call, we put her back, she's out in Utah at this point, we put her back on the protocol for treating the biotoxins, and within a month, everything is cleared. So we go, okay, there's something here. So this was the beginnings of our working with biotoxicity in particular, but it was also a real point driven home, something else had happened. And I had seen this in so many people for so long, and I was trying to understand why it was that all these events were happening. How could they be cumulative? Or were they related? And this is what we were trying to understand. We now understand how they connect, and this is what this book is about. And it's because we now understand how they connect that we can begin to talk about total recovery from these conditions. But let's first talk about these conditions. Talk about pain. Chronic pain, according to the latest Institute of Medicine study in 2011, affects almost a third of Americans, 100 million people. Pain comes in a lot of different forms. It comes in chronic headaches. It comes in the form of chronic back pain. It comes in the form of fibromyalgia. this generalized pain problem, comes in the form of chronic shoulder, and for the most part, a vast majority of it is misdiagnosed. Because we keep thinking it's the thing, it hurts here. And we keep looking here, we keep treating here. For some reason, even though we keep treating here, it's not getting better here. We have to think differently about these problems. What's the leading cause of disability in the United States for ages 15 to 44? Anyone got a guess? I'm sorry? Backache. What else? Major depressive disorder. It's the leading cause of disability in this country. All right? So we've got 100 million people suffering with chronic pain, and then we've got a lot of people suffering with neuropsychiatric problems. All right? How many? Well, major depressive disorder in any given year, 14.8 million people. Dysthymia, this chronic depression that goes on for years, kind of low grade, 3.3 million people. Generalized anxiety disorder, 6.8 million people. Post-traumatic stress syndrome, 7.7 million people. And the number one cause of post-traumatic stress syndrome? Not combat overseas, though that does affect 15% of our veterans. Car accidents. Car accidents. Several million people a year suffering from post-traumatic stress syndrome from car accidents. The majority of people involved in a significant car accident will suffer some level of post-traumatic stress syndrome for a year following the accident. Panic disorder, another 6 million people. In all, we're talking about 38.6 million people suffering with neuropsychiatric illnesses. Now, why do we care about this? We care about this because for some reason, we were seeing lots of people and continue to see lots of people who suffer with both chronic pain and depression or panic disorder. And it was driving me somewhat batty, trying to understand why it was. And worse was, when we treated one frequently, the other would get worse, and vice versa. And so, I asked some colleagues to sit down and start talking about this. Dr. Jose Apud, who's here this evening, was one of the psychiatrists who joined us in our group. And so every quarter or so, a group of about 6 of us would meet and try and understand what was common about these cases we were seeing, what it is that was going on. Well, the first question is, how common is it to see these conditions together? And the answer is very common. So if you look at the literature, 50 to 65% of people who suffer with chronic pain will have neuropsychiatric illness in condition with it. So you've got pain and depression are actually far more common together than they are apart. Okay, now why is that? First question is, what have they got in common? One of the things they have in common is a lot of the same areas of the brain are impacted by depression as are impacted by chronic pain. And these are all from functional MRI studies. So we see different areas of the brain are dysfunctional in chronic pain and in depression, and there's a huge overlap. So we've got some neuroanatomy in common. The other thing that we see is discordance versus symphonic. How the brain relates to each other's parts, how the brain talks to each other. So when the brain works, it's not this piece works and then that piece works and this piece works. It all has to work in coordination. One part needs to talk to another part, and they need to do so in a synchronous manner. And if they do so properly, you get this beautiful symphonic sound. You get order out of chaos. You get the ability to take all of this information, organize it, and put it into a coherent form. When the brain isn't talking to each other's parts appropriately, you get chaos. You get the discordant sounds. Now what you get is sharps and flats, and everything is out of tune. What you experience is problems focus, concentration, confusion, maybe some paranoia. but the brain isn't coordinating in the way it needs to talk to itself. And we see similar discordant patterns in chronic pain and chronic depression. So again, we see this similarity in which the brain stops functioning properly in both these conditions. Neurons are thought to be the main structure of the brain where everything works. It turns out we're not quite right on this one either. But if we stay with this for a second, neurons are how information moves about the brain. And they communicate not by touching each other, but they communicate by sending out packets of information from one to the other called neurotransmitters. And it turns out, serotonin being the most famous of this, right, made famous by listening to Prozac, serotonin, norepinephrine, dopamine for that matter, most of the neurotransmitters are not released or available in the proper amounts in the areas of the brain that they should be in both chronic pain and depression. And it turns out that we see a lot of overlap in the medications that we can use for treatment of chronic pain, also for being able to treat chronic depression. So we see a problem in terms of the anatomy of the brain that overlaps. We see a problem with the way the brain communicates with each other's parts that overlap. And we see a dysfunction of the neurotransmitters that overlap. The other thing we see is inflammation in the brain. Now, inflammation in the brain is a great big deal because inflammation in the brain results in degeneration of the brain. The longer these problems are going on, the harder they are to fix because we're watching pieces of the brain literally get smaller. This is a very, very serious and a very important finding. We know that inflammation leads to loss of brain matter. So, what if we're thinking about this all wrong? We've been thinking that depression and chronic pain cause the inflammation, the dysregulation, and ultimately the degeneration that we see in brains of people suffering with these conditions. We're wrong. What we now know is that inflammation, the dysregulation, the degeneration of the brain are actually cause depression and chronic pain. Chronic pain and depression are symptoms of a brain on fire.